place of conventional radiology in rheumatology. And then before we talk about conventional radiology alone, we have to know what are the various imaging techniques that are available to us. Even in conventional radiology of late, the modern trend is using digital radiology, where you can get better resolution of the part that is examined. Then ultrasonography, angiography if necessary, particularly in collagen vascular disorders with DSA, digital subtraction angiography, MDCT, multi-detector CT, that is the latest, radionuclides, MRI, and of course PET scan. And before we deal with these conventional radiology and its role, we have to know what are the various types of arthritis we encounter. One, most common because everybody gets older, degenerative, inflammatory, collagen vascular disorders, they play a role, and then infective, metabolic and endocrinal causes, neuropathic causes, and miscellaneous causes producing arthritis. In fact, conventional radiological diagnosis depends upon various factors. First of all, observation. And then what are the parameters? Always I teach A, B, C, D, E, S are the parameters that you should look in a radiograph in order to conclude for the diagnosis of a particular rheumatological disorder. Analysis of the various parameters. And then integration, the positive points and the negative points, because no case, no individual clinical patient is classical of anything. Always there are biological and clinical variations. And then the differential diagnosis. Of course, finally, we have to report the final diagnosis. Can't go on hedging or wavering. In order to make a diagnosis, occasionally films alone are not enough. You have to have the clinical knowledge, the laboratory data, and integrated all these, you should give a final diagnosis. As I said earlier, digital radiography is much better today than the usual old conventional radiography. Particularly, for example, this case, a 42-year-old male complains of backache and difficulty in walking. What are the various findings that you see? What will be your diagnosis? Think for a moment and write down. Second case, a 37-year-old chronic paraplegic. He has been paraplegic for a long time, and this is the radiographic examination of the pelvis. What are the findings? As I said earlier, observation, integration, parameters, differential diagnosis, and ultimately final diagnosis. Of course, these all the cases that I am showing are classical. Although you may give a differential diagnosis, top priority should be for the final diagnosis. Another case, radiograph of the hand, cone down views of the second and third metacarpal heads, a 38-year-old female with painful hands. And this is the plain film of one of the hands. Both hands may show similar findings, but as an example, I just showed you the focusing on second and third metacarpal heads. Another case, a 30-year-old male with recurrent attacks, and those recurrent attacks of pain are only on the right knee. Again, observe, look carefully, write down the parameters, and then write the differential diagnosis or diagnosis. Another case, 42-year-old female. She is under treatment for a known collagen vascular disorder. Long time she has been on treatment. Now she complains of the shoulder pain, and these are the observations that you see. Sometimes these cases do belong to a spot diagnosis. You don't have to write down all the parameters and then come to a long conclusion. On the spot, you can diagnose this. Frankly, what you do not know, you can't see. The eye cannot see what the mind does not know. Because that's why I said the various disorders that you encounter clinically and then refer to radiographic investigation. And unless you have all those in your mind, you won't see the findings themselves. coming back, the first case, you see the X-ray of the pelvis. What are the findings? As soon as you see increased density of the bone, because 42-year-old male, there is relative increase in the density of the bones. And anthosopathy, the arrows point down to the ischial tuberosities, the irregular osteophyte formation. And also in the hips, particularly in the inferior portions of the acetabular cavity, there is dense reactive sclerosis and anthosopathy. So also at the sacroiliac joints. All these together indicate fluorosis. Of course, there is some fluorosis because of the sclerotic bones and metabolic disorder, you may get pre-degenerative changes. Now the second case is, again, a radiograph of the pelvis, para-articular soft tissue dystrophic calcification. See, extensive calcification or ossification. Radiologically, it is rather difficult to differentiate between calcification and ossification. Calcification eventually becomes ossification. And then when there is ossification, you see the cortical bone or trabecular bone, then you are sure it must be a bone forming lesion. And calcification, chondrolysis of the hip joints. Why? It is marked thinning of the hip cartilage, articular cartilage at the hip joint. So there is atrophy of the cartilage. That's why you call it chondrolysis. Because in immobilization you can get chondrolysis. Ligaments and tendons are calcified. Muscles are also ossified partly due to prolonged immobilization. This is all due to immobilization. You get dystrophic calcification and ossification, particularly the muscles and para-articular ligaments. Like a classical example, in a paraplegic, what are the findings you can get? This particular case, it is obvious because there is evidence of para-articular osteoporosis. The alignment, if you look into the, particularly into the second metacarpophalangeal joint, it is overlapping, almost telescoping. And marginal erosions you could see. And finally, soft tissue swelling, localized soft tissue swelling at the arthritic place. So this is classical of rheumatoid arthritis. In your own mind, you may think of other diagnoses such as psoriasis, Reiter syndrome, but there is no anthosopathy. That's why you can rule out those things. Gout, well, in the soft tissue there are no tophi, and the erosions have a overhanging margins, so that you shouldn't think in terms of differential diagnosis. And the other case is hemophilic arthropathy. We said the 30-year-old male and unilateral involvement, not a bilateral, to think of a systemic type of arthritis. Large lytic area in the medial condyle of a tibia, you could see, with sclerotic margins, and residual trabeculations are also noted, which are thickened. Also note deepening of the intercondylar notch of the femur. That is significant because there is hemorrhage at the cruciate ligaments attachment. That's why there is erosion. Degenerative changes, of course, are also noted unilaterally. So this is a classical case of hemophilic joint. The key clue is that it is male and joint is unilateral, monoarticle. This again a spot diagnosis, osteonecrosis of head of humerus. Wherever the osteonecrosis is seen, say metacarpal heads, rare but not unusual, and then hips, very common, you find this dense reactive sclerosis because of the ischemia and a fracture line. Not a complete fracture, but a radiolucent incomplete fracture. Sclerotic changes in the epiphysis, the fracture. Flattening also of the head of the humerus, primarily due to a collagen vascular disorder such as lupus. Other disorders also can produce, for example, scleroderma, other collagen vascular disorders can also produce osteonecrosis, but usually only after steroid therapy. Corticosteroids can also produce this. Now we come to the spectrum of arthritis. Already we have mentioned various types of arthritis. Now we come to the degenerative joint disease, also called osteoarthritis. Primary and secondary, these are the two major classifications. And occasionally you get osteoarthritis erosive, inflammatory component, inflammatory arthritis. So there are three varieties of osteoarthritis. In the primary, in the secondary particularly, post-traumatic. Supposing the patient has had a fracture or a old rheumatoid arthritis treated, infective arthritis treated, you may get ultimately secondary degenerative changes, post-inflammatory and now the other category is inflammatory type of arthritis. Most common rheumatoid arthritis could be juvenile or adult type of onset of rheumatoid arthritis. Non-rheumatoid also there can be inflammatory changes such as juvenile reactive arthritis, another common thing that we see in youngsters. Psoriasis, skin disease and the arthritis symptoms, Raynaud's syndrome, seronegative spondyloarthropathies. All these come under inflammatory category. The infective, viral, today smallpox is rare, but post smallpox, say 3 decades ago, 4 decades ago, we had a smallpox epidemic and residual changes. There are survivors from smallpox, occasionally you may see one or two. And then bacterial, common, pyogenic, either staphylococcal, streptococcal, gram negative or gram positive. And then tuberculosis is very common pyogenic type of arthritis. Leprosy is another. Fungal arthritis, spirochetal. Syphilis, of course, is rather rare today, but still occasionally you see. Parasitic. A common is hydrated disease of the bone. And then HIV-related arthritis. Now coming to the category of collagen vascular disorders. One is rheumatoid disease. Second, progressive systemic sclerosis or scleroderma. Systemic lupus erythematosus, rheumatomyositis, and sometimes we get mixed type of or overlapping disorder of all these arthritis. We come to the category of metabolic and endocrine disorders. In the metabolic, gout is a uric acid metabolism and gout is a common presentation in elderly people. Polyarticular CPPD, what is CPPD? Calcium pyrophosphate crystal deposition disease. This deposition disease commonly you may see say 5 to 10% of the older people. It's incidental. Of course, they do have arthritis symptoms, but this is an incidental finding. Supposing a patient comes for a trauma of the knee, you may find this chondrocalcinosis, incidental. Hemochromatosis, ochronosis, all these are all metabolic disorders. Wilson's disease, due to deficiency of the ceruloplasmin and copper accumulates. We go into details later. Diabetes, arthropathy, and then you can get calcium deposition, osteoporosis, Cushing disease, acromegaly, hyperparathyroidism. These are some of the metabolic and endocrine disorders that we come across. Then how do you approach? There is a film, clinically they think of an inflammatory type of arthritis. You got a film. How do you approach? There must be some parameters. Radiological parameters. That's why I always say A, B, C, D, E, S type of arthritis. This has become so popular. Now most of the rheumatologists also follow these parameters. A, alignment. B, bone density. And then C, cartilage, whether it's atrophied, hypertrophied, calcified. And then distribution. Is the metacarpophalangeal joints that is prominent or distal interphalangeal joint? What are the target areas for each degenerative disease or rheumatoid arthritis or in fact there are certain target areas. If you locate these target areas, immediately a diagnosis may flash in your mind. Erosions, E represents erosions or evernations or enthesopathy. Evernation is sclerosis, entirely opposite of erosion. Erosion is excavation of the margins, articular margins. And enthesopathy, production of osteophyte. And soft tissue changes, is there a swelling? If it is a swelling, is it symmetrical swelling or is it asymmetrical swelling? If there is a swelling, is there any calcification or even ossification? These are the various parameters. If you keep them in mind, in a computerized fashion, immediately the diagnosis flashes. Now, there are 3 types of joints, most of you know. Common is the synovial joint, or common in the sense, mostly involved in inflammatory, infective type of joints. And then, as you might see, C indicates a subarticular cyst. The E is erosion, H hyaline cartilage representation, O, enthesopathy, product to new bone, and P, periosteoitis. Periosteoitis is not that common, but occasionally you may see in rheumatoid arthritis, psoriatic arthritis, and hypertrophic osteoarthropathy, etc. Now we come to the first parameter, alignment. Alignment could be subluxation, or 3/4 of it may be out, then we call it dislocation, and then there may overlap or protrude into one bone into another. That is what is called telescopy. That is a tertiary form of inflammatory or neuropathic joint manifestation. Subluxations you could see, for example, rheumatoid arthritis. Early on, the synovium is involved, annus is formed, erosions occur, and because of the laxity of the ligaments, subluxations do occur. Not only in rheumatoid arthritis, in lupus, subluxation is very common. So you have to find out one parameter, subluxation, but then subluxation alone doesn't give you the diagnosis. Look for the other parameters. Then rheumatoid arthritis spine, C1, C2. Look at the subluxation at the atlantoaxial joint. These are all the subtle forms of subluxation. Occasionally, the odontoid peg may be completely resolved and complete dislocation may occur, and we have seen patients even in the radiology department getting into quadriplegic because of the subluxation aggravated with the positioning with the technician. Neuropathic joint subluxation and dislocations are common, and as I said earlier, you have to look for other parameters to say that is a neuropathic joint. But what I am stressing upon is alignment problems very common in neuropathic joints also. Telescopy, one bone, look at the acetabulum. There is a protrusio acetabuli, thinning of the acetabulum, and the head of the femur protrudes into it, and that's how the acetabulum cavity is bigger, coxa magna they call it. And then, but the head of the femur is small because of the erosions. This is rheumatoid arthritis. The cartilage is not much involved. It's all synovial process. Eventually, of course, the cartilage also gets affected. And now we come to the second, AB, bone density. How does it help? Para-articular osteoporosis, either presence of it or lack of it determines the diagnosis. Osteoporosis is present at the articular margin, para-articular, not in the shafts. Rheumatoid arthritis is advanced. Not only there is subluxation and dislocation, marked para-articular osteoporosis at the metacarpophalangeal joints and interphalangeal joints. Subluxation of first at MCP, metacarpophalangeal joint, collapse of carpal bones, complete erosion and then collapse, and penciling of ulna, that is due to circumferential type of resolution of the bone. That's how it results in a pencil type of, and of course, telescopy into the wrist. Again, para-articular osteoporosis with erosions, rheumatoid arthritis. We have seen this earlier, soft tissue swelling, para-articular erosions, and para-articular osteoporosis. Juvenile rheumatoid arthritis. What are the features? Again, osteoporosis. Because it is a chronic, there may be generalized osteoporosis, not only juxta osteoporosis. Here, of course, juxta-articular osteoporosis is also there. The epiphyses are large because of the hyperemia. Erosions, if you look carefully, there are subtle erosions. This is the case of juvenile. Another case, most of the changes in the corpus are probably due to treatment. The corpus are eroded and resolved, they become small. Para-articular osteoporosis again, infective disorders also, not only inflammatory disorders, infective disorders, particularly acute infections, very common. This is tuberculosis of the tarso-metatarsal joints. Para-articular osteoporosis. Because of the pain, the patients are immobilized or they are not so mobile, you may get generalized osteoporosis also. But para-articular osteoporosis is quite important, along with erosions and obliteration of the joint space, etc. Systemic lupus erythematosus. The erosions are not very common as against rheumatoid arthritis, but subluxations are common because of the laxity of the ligaments. Para-articular osteoporosis, no gross erosions or subluxation. Swan neck type of deformity due to relaxation of the ligaments. This is another entity called reflex sympathetic dystrophy syndrome, or earlier we used to call it Sudex atrophy. Radiological findings almost simulate rheumatoid arthritis, namely para-arterial osteoporosis, diffuse soft tissue swelling, and not localized soft tissue swelling along the para-arterial margin. And erosions also you may see in some cases, chronic cases. But then it involves only one portion of the limb, one hand or one foot. It's not bilateral nor symmetric. HIV-associated arthritis, it may be any type of infection, viral. All sorts of infections do occur in HIV-related arthritis. Marked osteoporosis, diffuse osteoporosis, localized, obliteration of joint spaces, non-specific finding of acute infective arthritis. From this, can you tell it is staphylococcal? Can you tell it is hemophilic? Influenza? You can't tell. Paucity of para-arterial osteoporosis, that is another parameter in order to determine which type of arthritis we are dealing with. This is primarily osteoarthritis, primary osteoarthritis. Here, what is important is not only lack of osteoporosis, but the target areas, distal interphalangeals of the joints of the hand. There is narrowing, there is everation, there are osteophyte formation. Same thing with the knee. In the rest of the skeleton, you get, especially in the peripheral joints, the weight-bearing type of joints, you get degenerative joint changes. Of course, since our primary osteoarthritis is primarily in older people, generalized osteoporosis also you may find. Again, to say there is no para-arterial osteoporosis, here patient comes with pain in the wrist, young patient, erosion with synovial hypertrophy. Look at the outer portion of the scaphoid, erosion with the sclerotic border. This is pigmented villonodular synovium. Can you tell? Radiologically, it's definitely PVS, not easy. But you have to eliminate erosive arthritis only involving one bone, one portion. With a soft tissue swelling, that means it is a synovial process. It cannot be a synovial tumor because there is no osteoporosis. Not only that, erosion is associated with the sclerosis. So by elimination, we can come to the conclusion that it may be pigmented villonodular.